Good afternoon. Before we begin, I would like to let everyone know that this session is being recorded. These recordings will become available on our Dent Echo website after the session. And we are very excited to have all of you join us for the 24th Dent Echo. This session is brought to you by the UT Health San Antonio School of Dentistry. And my name is Kato, and I will assist in facilitating today's session. Next slide. Thank you. And here's our agenda for today. We'll start off with some announcements and introductions, then move on to didactic presentation by Dr. Carey and case presentation by Dr. Chachapan, with time for Q&A at the end. Next slide. And some notes before we get started. These sessions are recorded for later distribution on our Dent Echo website. Please stay muted unless you are speaking. You can also use the chat to raise questions and share your perspectives. The slides and recording will be made available on our Dent Echo website after the session. And to help us with attendance, please enter your name, affiliation, and email into the chat. Please remember that no personal health information is allowed in either the chat or our discussions. And if you would like assistance with your connection throughout the session, please chat Karen, our Dent Echo IT. Next slide. And for those who may be new to Echo, this is a model that builds virtual communities of practice and learning. Sessions include a didactic presentation and de-identified case-based learning, and group discussion to foster deep knowledge and build individual capacity. Echo is an all-teach-all-learn supported model, and Echoes thrive on the interaction from the full learning network. So we encourage everyone to participate in the conversation today. And we also encourage you to join by video if you can. Next slide. And to receive CDE credits, please make sure to be on the session throughout the duration of the presentation. If you would like to receive CDE credits, make sure to register through Smile, which you can do so now using the link in the chat or by scanning the QR code that you see on the screen. And when registering, please use the supercode ECHO 2024. Thank you, Karen. Please unshare the slides. Thank you. And let's move on to introductions. Dr. Challa.
Thank you, Kito. Hi, welcome, and thank you all for taking the time to attend this meeting. And I'm Suman Challa, the principal investigator of this grant, that postdoctoral grant that supports this Dent Echo.
Thank you so much for joining, Dr. Challa. And from the Hub team, we also have Dr. Dar and Dr. Rankar on today. And I will now pass the mic over to Dr. Dar to introduce today's speakers, Dr. Carey and Dr. Chachapan.
Thank you so much, Geeta. It's my absolute pleasure to welcome Dr. Carey and Dr. Chachapan to our Dent Echo session this afternoon. Dr. Carey is a board-certified pediatric dentist, educator, and child advocate. Dr. Carey began her professional career as a high school teacher in Bahamas, where she witnessed a startling oral health disease burden among children from the disadvantaged backgrounds. A visionary change agent, she was compelled to pursue a career in dentistry to help address the crisis and the burden of oral health care and disparities. In 2015, Dr. Carey earned her DMD and MSCD in higher education from University of Pennsylvania before going on to complete a pediatric dental residency at University of Minnesota. In 2017, Dr. Carey returned to the Bahamas, where she worked in private practice and public health. However, her affinity for teaching and mentoring led her back to academia. Dr. Carey currently serves as Clinical Associate Professor in the Department of Developmental Dentistry at UT Health San Antonio. Previously, she has served as Clinical Assistant Professor at NYU College of Dentistry and University of Florida College of Dentistry. In addition to expanding care to vulnerable child populations, Dr. Carey's interests are interprofessional education and collaboration, innovation in education, and healthcare models and success and well-being in healthcare education. Thank you, Dr. Carey, for presenting to us this afternoon. Our second presenter for the Dent Echo session is Dr. Chachapan, who is a first-year pediatric dental resident with a keen interest in integrating technology into clinical practice to improve pediatric dental care. With a strong foundation in public health, research, and clinical dentistry, she is currently exploring the potential of AI to enhance diagnostic accuracy and treatment planning for pediatric patients. Dr. Chachapan earned her BDS degree from India. After practicing briefly in India, she moved to the United States and completed her Masters of Public Health from University of Alabama at Birmingham in 2016. She subsequently worked as a research assistant at UAB for a year before undertaking 2 years in advanced clinical training in restorative dentistry at UCLA School of Dentistry, graduating in 2021. From 2022 to 2024, Dr. Chachapan practiced as a licensed general dentist at 2 FQHCs in California, where she gained firsthand insight into the challenges faced by pediatric patients and families, particularly those reliant on Medi-Cal. Driven by her commitment to addressing these gaps in care, she is now pursuing a master's degree in pediatric dentistry with aspirations to contribute to the fields of pediatric and restorative dentistry, public health, and research. Beyond the clinic, Dr. Chachapan enjoys traveling, jewelry making, exploring the slopes as a novice snowboarder. Welcome, Dr. Chachapan. Over to both of you. Thank you again for presenting for Denteco this afternoon.
Thank you. Thank you so much for that introduction. And I would like to jump into our presentation today, which reviews stewardship, antibiotic stewardship in pediatric dentistry. And just gonna get my slides to advance. Awesome. So an overview of the presentation, we're going to look at what antimicrobial resistance is and its global impact, as well as its impact locally within the US. We'll look at some of the unique challenges for antibiotic use within the pediatric population. And then we'll do a brief overview of use of antibiotics in dentistry. And finally, we'll conclude with understanding some principles of antibiotic stewardship and how we can be more judicious in our use of antibiotics as we practice. So antimicrobial resistance is a global problem. The World Health Organization declared that antimicrobial resistance is one of the top 10 global public health threats facing humanity. The CDC has declared that antimicrobial resistance is one of the greatest global health challenges to modern medicine. And without urgent action, we're actually heading for a post-antibiotic era in which common infections and minor injuries can once again kill. And there are some pretty stark estimates out there. For example, it's been estimated that by 2050, 10 million worldwide deaths could be attributed to antibiotic resistance. And that would make this issue more deadlier than cancer. So what is antimicrobial resistance? Specifically, we're talking about when microorganisms like bacteria and fungi develop the ability to defeat drugs that were designed to kill them. This is a naturally occurring process. However, there can be selective pressures that accelerate this process. And when that happens, resistant infections can be extremely difficult, sometimes impossible to treat. So if we look more locally within the US to understand how serious or how impactful this issue is, this is an antimicrobial threat report that the CDC published in 2019. And it showed that there were national estimates that 2.8 million infections are related or associated with antimicrobially resistant organisms that result in 35,900 deaths annually. And there's also the problem of Clostridium difficile infection that creates significant morbidity and mortality for patients, contributing to up to as many as 12,800 deaths a year. And not only does it increase morbidity and mortality, but there's also extensive cost associated with caring for patients who are experiencing infections that are resistant to the antibiotics that we use. And so you have extended hospital stays, extended medication therapies that is estimated to cost the US at least $4.6 billion annually. And that's only looking at antibiotic infections that are resistant to 6 microorganisms. So if we review another updated data set from the CDC, because one might say, well, that was 2019. We're 6 years out in 2025. Are we doing any better? So with this knowledge and with all the efforts to decrease antimicrobial resistance within the US and across the globe, unfortunately, we're still trending upwards with the number of antimicrobial resistant infections we're seeing annually. There was a downward trend between 2013 and 2019, but with the COVID pandemic, antimicrobial resistant infections spiked due to the increased hospital stays and the increased number of hospitalizations in general. And unfortunately, we just haven't seen those numbers come down since the pandemic. And so we are still trending upwards towards still having to deal with more infections. So how did we get here? What causes this process? We know it's a naturally occurring phenomenon. What are some of the selective pressures? So as we exist, lack of clean water and sanitation can certainly contribute. Inadequate infection control, inadequate infection prevention like vaccinations. All of these things promote the spread of microbes. And some of the microbes that are spread around are going to be resistant to antimicrobial treatment. But the main drivers that contribute to the development of the drug-resistant pathogens is going to be misuse and overuse of the antimicrobials. And this can be in any context, whether it be with people, animals, or crops. They all can lead to resistance among microorganisms that contribute to this problem. Another challenge is that we have not produced antibiotics or new antibiotics for a while. So there was a time of antibiotic discovery referred to the golden period between 1930 and 1967. There was a lot of discovery of new antibiotics, and then it slowed down. And the last time we had a new antibiotic or a new class of antibiotic discovered was in 1987. And that drug did not make it to market until in the early 2000s. So it is a lot of research that goes into developing antibiotics, and it takes a long time to get to market. Unfortunately, even after years and years and millions of dollars spent on research, sometimes the drug won't even make it to market. So it gets scrapped. So pharmaceutical companies don't have much incentive to pursue creating new antibiotics. So the development or the pipeline for development is pretty dry at this point. And even if we were to develop new antibiotics, it's not going to be enough because of the behaviors that we have that lend to the problem. So without behavioral change, we would unfortunately end up in the same place, even with one or a few more antibiotics being introduced. So now I'm going to switch gears and review some of the challenges we have with using antibiotics in the pediatric population that might not be an issue in the adult population. So firstly, antibiotics are the most frequent cause of adverse drug events, leading to emergency department visits in children. Nevertheless, they continue to be the most commonly prescribed drugs in children. Additionally, antibiotic exposure is linked. Early antibiotic exposure is linked to chronic conditions. And so a lot of the research has looked to antibiotic exposure in kids under 2. And there has been associations with the development of chronic conditions as a result of intestinal dysbiosis occurring when antibiotics are introduced early on. So there are host biome interactions that are required in the early life that will allow proper development for metabolism, for behavior, for neurologic development. And when that's disrupted early on, we definitely see a lot of chronic conditions specifically related to behavioral conditions and cognitive functioning. And so we know that the gut is the second brain. And so any disruption early on impacts neurologic development. And this article is here for your reference, just in case anyone wanted to look further into the studies related to these associations. So there was a large cohort study out of Minnesota, and they looked at kids between January 2003 and December 2011. And they looked at children who had received at least one antibiotic prescription during the first 2 years of life. And they found that early exposure was related to a number of conditions. The findings reflect associations and not causation, but there was certainly a correlation with earlier exposure and more frequent exposure to risk of having some of the conditions highlighted. So next, we're going to look at the use of antibiotics in outpatient settings. And of course, in dentistry, most of our antibiotics are in the outpatient setting. So most antibiotic use occurs in outpatient setting, estimated as much as 80 to 90% of human antibiotic use. And this is data from the CDC. So in 2020, the CDC found that healthcare providers prescribed 236.4 million antibiotic prescriptions. And roughly that correlates to 7 prescriptions for every 10 people in the outpatient setting. And they found that at least 28% of those prescriptions were unnecessary. And unnecessary could mean it was either the inappropriate antibiotic was selected, or it wasn't the right dose, or the duration was not correct. And if we zone into dentistry, there was a study published in 2019 that assessed the appropriateness of antibiotic prescriptions for infection prophylaxis before dental procedures. And in that study, they found that 80% of the antibiotics were not needed, or 80% of the prescriptions were not needed. And so again, that is roughly estimating nearly 81% of the scripts we're prescribing prior to dental procedures is unnecessary. And if we want to understand how much we're contributing to the problem, I've included this table that shows by provider who's prescribing what. And so if you look at this table, dentistry is third in terms of provider that's prescribing the most amount of antibiotics. So we come in just behind primary care physicians. And so in 2022, dentists provided 25.2 million antibiotic prescriptions. And so we are definitely a significant contributor. The key takeaway from the CDC data is that the most important modifiable risk factor for antibiotic resistance is inappropriate prescribing of antibiotics. And so to that end, the CDC has implemented many efforts to expand antibiotic stewardship. And so pretty much antibiotic stewardship in summary is being judicious with the use of antibiotics. And there are efforts put in place to measure antibiotic prescription or measure antibiotic prescribing practices. You want to improve prescribing by clinicians and use by patients so that antibiotics are only prescribed and used when needed. It's also efforts to minimize misdiagnosis or delayed diagnoses that can lead to underuse of antibiotics. And we're also wanting to ensure that the right drug, dose, and duration are selected when an antibiotic is indicated. So additionally, there was an antimicrobial resistance challenge funded by the US government to accelerate the fight against antimicrobial resistance. And this challenge ran from 2018, so from September 2018 to September 2019, and it was a part of the UN General Assembly side events. And the challenge resulted in more than 350 organizations across the globe committing to slow down antimicrobial resistance. Fortunately for us, the ADA was a part of this side event, and they also pledged commitment, and they committed to 2 things: that they would create and disseminate guidance to help clinicians appropriately prescribe antibiotics for dental pain and swelling. And then they also committed to publishing a survey of current antibiotic prescribing practices among dentists to demonstrate the need for such guidance. And to that end, in, I think it was November 2019, we had the first ever ADA clinical practice guideline published. It was the cover page of the JADA article that month. And it is also the first ever dental guideline that's endorsed by physicians. And so they had a task force or a scientific panel of many disciplinarians and subject expert persons. Unfortunately, they did not include pediatric dentistry in this conference, yet much of the data to support the recommendations are actually from pediatric population studies. And so that's my pet peeve with this beautiful guideline. And additionally, it says that the scope of the guideline focuses on immunocompetent adult patients. But if you look at the references, a lot of the literature to support the recommendations are actually out of pediatric studies. Key points from this guideline is that it recommends against using antibiotics for most pulpal and periapical conditions, instead favoring to actually do treatment. So if you can get in and do treatment, that is preferred as opposed to prescribing and delaying treatment. In cases where a patient's condition progresses to systemic involvement, and that would be showing signs of fever, malaise, and maybe other factors like trismus, then certainly antibiotics should be prescribed as adjunctive therapy. So even though peds dentistry wasn't invited to be a part of that panel, the AAPD since 2001 has put out some very good guidelines on the use of antibiotic therapy for pediatric dental patients. And similarly, we've been advocating in pediatric dentistry for judicious use, only using antibiotic therapy as indicated. And so being very specific and intentional of not using antibiotics if the infection is limited to the pulpal tissue or the immediate surrounding tissue. So if you have a localized infection, the AAPD has been pretty consistent with advocating for treatment over prescribing antibiotics. So that gives us a challenge. We need antibiotics as an important adjunct in managing orofacial infections. So how can we ensure that we're using them judiciously in our practice? And that leads me into the last portion of the presentation, which is reviewing some of the guidelines for the judicious use of antibiotics. And so there are 6 key principles that I'll highlight and go over. So the first one is using therapeutic antibiotics only when clinically indicated. So when are antibiotics indicated? And again, this is just a reference. Historically, we've been exposed to these indications throughout our training, but this is the classic 7 indications within dentistry. And we can have acute cellulitis, pericoronitis, deep facial and space infections, open fractures, extensive or deep orofacial lacerations, dental infection, or OMS in the compromised host. And so, of course, there's different recommendations if your patient is immunocompromised. So these are the indications mostly for immunocompetent patients. And then prophylaxis for dental surgery for some patients with valvular cardiac disease or prosthetic valve. There might be extended indications in pediatric patients. So an avulsion can happen in an adult patient as well. So when we're looking at avulsion, it's with permanent teeth, whether the apex is open or closed. You can consider adjunctive therapy. The consensus on whether to use or not use antibiotics in managing avulsion, there's no consensus as to yes or no. And so it is put there as a possibility that you can supplement your therapy with antibiotics. Certainly in the management of periodontal disease associated with systemic conditions, localized antibiotic use is certainly sometimes indicated. Additionally, salivary gland infections, and as we saw previously, odontogenic infection with cellulitis. So the second principle is that surgery should be implemented to remove the cause of the infection and establish drainage. And that's the primary goal. Antibiotics are just adjunctive therapy. And so in managing infectious disease, there are two cardinal strategies, which is source control and then the antibacterial chemotherapy. And source control is the physical removal of the infected material, and that is the cornerstone of treatment. We want to get in and remove the infected tissue. If you can remove the infected tissue, whether that be via endodontic reamers to remove the infected pulp or an extraction to remove the infected pulp, that is primary. Definitely important to consider when you should use antimicrobial therapy, and if so, when to start so that that therapy can be as effective as possible. So a big question that has often come up in oral surgery is when to extract a tooth in the presence of a systemic infection. So if you feel like antibiotics are indicated, how long should you wait before you extract the tooth? And generally, when I have orofacial infections and I consult with oral surgery, oftentimes they're always recommending that as soon as I can get into the patient's oral cavity safely and the patient can be numb, so profound anesthesia is a must. If I can get the patient profoundly numb and this can be done safely, that's when you want to do the extraction. So there's no time to say, I'm going for 5 days before I get in or 7 days. So as soon as safely possible, given the patient's medical condition is stable, that's when you want to get in and do an extraction. The longer an aquatic tooth remains, the more likely it is to cause a facial space or fascial space infection that will lead to greater morbidity and possibility for mortality. Another principle is using specific antibiotic therapy as soon as possible based on culture and sensitivity testing. And so in dentistry, when we are prescribing antibiotics, most of the time we're prescribing empirically. So we're using educated choices about the likely agents that are involved in the infection, and we're selecting an antibiotic based on that knowledge, as opposed to actually taking a sample of the infected tissue and figuring out which bacterial or microbial agents are present. And again, because we're prescribing empirically, this also is important that we remove the nidus of infection as early as possible, since we don't always know that we've selected the right drug. Generally, most head and neck infections are caused by a combination of gram-positive cocci and anaerobes, and the oral flora involved in abscess of odontogenic origin in pediatric patients is similar to that of adults. So empirically, we kind of prescribe the same drugs across adults and pediatric patients. So selection of antibiotics should be based on properties of the agent, the patient's history of previous antibiotic use, and any other considerations for the patient, medical history, drug allergies, and also route and ease of use. And this is specifically important for pediatric patients. So this list here just kind of highlights some of the go-to drugs or more commonly used drugs to manage odontogenic infection. Amoxicillin is considered the first drug of choice for dental infections in non-allergic children, and is pretty effective against the oral flora. It's well absorbed from the GI tract, provides a high sustained serum concentration, and generally has a low incidence of adverse effects. It's also tastes pleasant for kids, so compliance is pretty good with amoxicillin. For patients who are allergic, you have several options: clindamycin, azithromycin, or doxycycline. Clindamycin does carry now a boxed warning against C. diff infections, and so the AHA has removed it as a recommended drug for prophylaxis against infective endocarditis. And so there's also caution with using clindamycin in managing odontogenic infections in kids because they are susceptible to C. diff infections. There's azithromycin as an option. It's a safe option, but there's a risk for cardiac complications in patients who have cardiovascular risk factors, so something to consider. Doxycycline can be recommended as an alternative. I know a lot of persons are shy to use it because of historically it causes staining in both primary and permanent dentition. So If it's used short term, it does not cause staining, short term being less than 21 days. It can be considered. So just here historically, I know a lot of people don't use doxycycline in kids. I have not prescribed doxycycline for odontogenic infection, but sometimes it might be considered for avulsion. You want to use evidence-based medicine and guidelines when available. That's harder when we're managing pediatric patients because we're not able to do as many randomized controlled trials within the pediatric population because of this restrictions of doing studies in that population. So we don't have a ton of data or studies to use. However, generally we would use consensus information gathered by expert panels, and they review available literature and potentially other literature across the globe and some adult literature and make recommendations based on those findings. And so it's great when we have a consensus guideline. The ADA guideline, clinic practice guideline that was published in 2019 is one of those expert guidelines. However, there was a survey done that looked at prescribing habits across dental students, dentists, and pediatric dentists. And generally what they found was that adherence to professional clinical guidelines was low. And so oftentimes people practice the way they train, and in spite of new evidence coming out. And so with the, with the large scale impact that antimicrobial resistance has, both locally and globally, we're hoping that behaviors can change as people are more educated about the challenges. A fifth guiding principle is to use the narrowest spectrum empiric antibiotic effective against the most likely pathogens. So for us, it's kind of tricky because when we're treating odontic infection, it's a number of agents that could be causing it. And so we kind of need a broader spectrum antibiotic that covers anaerobes and other agents. So we tend to go a little broader spectrum. Amoxicillin and the penicillins can be broad in terms of agents that they cover, but it is the first choice. And so I guess our adaptation here would be using the first line of antibiotic first. And so we know the empirical choice is going to be amoxicillin, so using that as our go-to first, unless the patient has an indication why we cannot use that. And so when we use first-line antibiotics or narrower spectrum, we're reducing pharmacologic toxicity, we're reducing environmental selective pressure for antibiotic resistance. We're usually saving costs to the patient. We're more likely to have the infection resolve in a timely manner and reduce morbidity and other associated adverse events. And the last concept I'll cover is minimizing the duration of antibiotic therapy as appropriate to the presenting type of infection. And this one I know is different than how many of us were trained. So oftentimes we start antibiotics empirically. So it's recommended that we do an antibiotic timeout. And what is that? That's a formal reassessment of the continuing need and choice of antibiotics when the clinical picture is clearer and more diagnostic information is available. So oftentimes we prescribe to the patient, tell them how many days to take it, and off they go. And we never check back in to see, did those antibiotics work? We didn't culture the specimen, so we don't really know if we chose the right drug. So the ADA Clinical Practice Guideline has incorporated this antibiotic timeout recommendation, and they have a statement that specifically says clinicians should reevaluate within 3 days. So either in-person visit or phone call. Additionally, they go on to say that dentists should instruct patients to discontinue antibiotics 24 hours after their symptoms resolve, irrespective of reevaluation after 3 days. So you're giving this instruction to your patients as they are preparing for antibiotic therapy. The AAPD has similar recommendations. They say that the clinician should consider altering or discontinuing antibiotics following determination of either ineffectiveness or cure prior to completion of a full course of therapy. So previously, we have been led to believe that you have to complete antibiotics or the full course to prevent antimicrobial resistance. That actually promotes antimicrobial resistance. And so that's unfortunately been a myth that has perpetuated within medicine and dentistry. So essentially, when you start antibiotic therapy, the drugs or the microbes present can either have resistance or not. So if the microbes have resistance from whatever exposures they've had previously, if they are resistant to your drug, once you start your drug therapy, you're not going to be able to kill those microbes with that drug. They already have the features that allow them to evade that drug. What you will do is kill other susceptible bacteria. And what that does is allow the population of the resistant bacteria to increase unchecked, both by your antibiotic and by other microorganisms that are now being killed off. And so shorter courses will allow you to give less advantage to microbes that are resistant. So is shorter courses of antibiotic therapy effective? I'm going to be quoting James Hupp, who is well known throughout oral surgery, and this comes from Head, Neck, and Orofacial Infections, a book that was published in 2016. So in odontogenic infections, there were 2 randomized clinical trials that compared 3 to 4 day antibiotic courses with 7 to 10 day courses. They found that there was no difference in clinical effectiveness between the groups, so long as the appropriate dental or surgical treatment was performed. So that being incision and drainage, extraction, or endodontic treatment. There are other places where they've compared short course to long course, and they've found the results to be equally effective. So bottom line was that shorter courses are effective and often preferred for many reasons. One, they're more likely to be completed properly. They have fewer side effects. They're likely to be cheaper, and they reduce the exposure of bacteria to antibiotics, which reduces the speed by which pathogens would develop resistance. And this is especially helpful for kids. Shorter courses are preferred to longer courses because they're just going to be more likely to be compliant with the shorter course. And that is just as a result of observing that compliance is extremely poor with longer courses. So what is our duty? As healthcare professionals, we're at the front, we are frontline stewards, and we're challenged with balancing appropriate antibiotic prescribing with the withholding of unnecessary usage. Thank you.
Thank you so much, Dr. Carey. Yes. Does anybody have any questions for Dr. Carey? Please feel free to type it in the chat if that as well. All right, let's move on to the case presentation portion of today's session. Dr. Chachapan, whenever you're ready, please take it away.
Let's see, this could be. That's a good PowerPoint. Yeah, it's already up. Yep, and now where's your PowerPoint? Yeah, it's right there. And then full screen presentation. And then right click share present view. Sure. Show present view. And then you'll have to move that to fit your screen. All right, and Dr. Chachapan will be starting in just a second.
And if you have any questions, please raise your hand or type it in the chat. Great, it looks great.
Sorry about the delay, guys. So I'm going to start with the case presentation portion of this presentation. Let me introduce you to our patient, Matthias. He's a 5-year-old who came into the clinic with his mom presenting with a facial swelling on the left side. According to his mom, the pain began 3 days ago, but the swelling only became noticeable about a day before their visit. When I asked Matthias if it hurt to eat or drink, his responses indicated that functionality wasn't significantly affected. He wasn't in pain. However, he did rate his pain as a 6 out of 10. From these details, we can already begin to piece together a pattern. It seems the issue started out with an acute pain and has since progressed to a more acute exacerbation of the infection, which might explain why his pain is more moderate rather than severe. But the question we're all trying to ascertain is whether antibiotics are appropriate in this case. We'll need to evaluate further to confirm and decide on what the best course of action here is. Overall, Matthias is a healthy child, although his BMI does place him in the obese category. When he presented to the clinic, his vital signs were within normal limits. Everybody pay attention to that. Showing no immediate red flags or concerns at the time of evaluation. Matthias obviously was accompanied by his mom. She has no insurance and she opts to pay for treatment. Upon reviewing the chart, we also noticed that the family has a significant pattern of missed or canceled appointments. And so I evaluate the patient intraorally, and the infection presents itself as a well-defined localized abscess on the buccal surface of number I. On the slide, the image on the left is very similar to the clinical presentation from our patient. Now, turning to the image on the right, this is a periapical radiograph that was taken during the appointment. We see the progression of coronal caries on number I extending into the pulp and the periapex, with number 12 situated in very close proximity to the affected area. Number I seems to most likely to be our antagonist. But at this point, it looks like any of these guys could be playing Russian roulette, because when we take a step back and review a series of radiographs, a bigger plot begins to unfold. And if I were to map out the caries for you directly on these radiographs, it would look something like this. Similarly, if I had to map out the progression of caries based on the surfaces recorded in EHR over a number of visits, which you're going to see in the next slide, you'd see a clear pattern of change over time. We move from the image on the left to the right, we see that there's a gradual spread of decay. Over time, the decay seems to invade more surfaces, progressively involving additional teeth, and it's a steady progression, which eventually brings us to a critical point where we have tooth number I that is now infected, and it has escalated to a critical stage. Like every good detective story, I begin the process of piecing together clues and sifting through suspects to find the offending tooth and the story behind it. So using a combination of percussion, palpation, endodontic testing, his reactions, radiographs, and an assessment of the type of swelling, all the evidence consistently points to tooth number I as the source of the problem. Using the elements highlighted in red, I arrive at the most likely conclusion that the pulp of number I became necrotic and infected and ultimately spread to the periapical area and into the buccal space. Like I mentioned, turns out Matthias was a patient of record at our clinic. He was initially referred at the age of 3 for an evaluation and management of dental caries. During his first appointment, the extent of the caries and his young age prompted a discussion with his mom regarding treatment options. She was informed that in-office sedation posed a significant risk, and full mouth rehabilitation under general anesthesia was recommended. She declined treatment under GA. At a second visit for a recall, an emergency treatment plan was developed incorporating nitrous oxide. Silver diamine fluoride was applied to all the carious lesions at both visits. At his most recent appointment, the emergency plan was implemented and number I was extracted with nitrous. If I could paint a picture of Matthias based on the summaries of his dental visits, it would look something like this. A happy child who once eagerly sat in the chair is now met with growing anxiety and fear. His dental experience has gradually become a picture of distress where he's facing the possibility of his first dental procedure being a tooth extraction. So it's pretty clear that intervention is necessary here. But the real question is, what's the best approach? We're dealing with some mild systemic involvement, especially with the facial swelling, which is odontogenic, definitely related to the dental issue at hand. It's localized yet progressive, and we can't afford to ignore it. So now let's complicate things a little bit more. We've got a history of disruption in the continuity of care, and compliance with recommended treatment has been less than ideal. So with these factors in mind, we need to carefully weigh our options to decide what's the best course of action moving forward. And when we take a look at AAPD's best recommendation, it's pretty straightforward. The clear guidance here is that surgical intervention should be pursued as soon as possible. No ambiguity, no gray area. When it comes to addressing this issue, time is of the essence. But before we jump into treatment options for Matthias, I wanted to take a step back and break down the problem to make sure we have clear, actionable goals. First, the most critical aspects here are addressing the infection, which is presenting itself as a swelling and an abscess, and of course, managing Matthias's escalating dental anxiety. Our primary goal, as always, is to eliminate the infection source and prevent it from spreading further. But on this note, I'd like to mention the story of how a 12-year-old named Diamante Driver tragically died from toothache in 2007 due to lack of access to timely extractions in Maryland. The moral of the story here, things can progress very quickly in children, and we can't afford to delay care. Now, beyond the infection, I also saw an opportunity to address some secondary goals by involving Matthias's mom in the treatment process. By partnering with her, I'm hoping to build trust and help her feel empowered to take proactive steps in preventing similar situations down the road. If she sees the impact of this experience, it might motivate her to prioritize care in the future. So when it comes to our options, unlike you fine folks who would have extracted the tooth in a heartbeat, I want to point out a statistic, and Dr. Carey mentioned this earlier. This was the statistic from the 2019 ACE panel, which is the ADA clinical evaluation report, the survey that she was talking about. They did that survey in 2019, and they found that the antibiotic usage in endodontic infections, especially for acute apical abscess, was 53%. 53% of the participants prescribed antibiotics for pulponecrosis with an acute apical abscess. This serves as a reminder that clinical practices can vary widely, just as she mentioned, and it's just a gentle nudge to align treatment with evidence-based guidelines. In Matthias's case, however, extracting the tooth is the most effective approach to tackle the infection and achieve our goals. So let's set the stage for the ultimate Dr. Carey special. Picture this. We've got a 5-year-old, and his first ever dental treatment experience is a tooth extraction, because who wouldn't want that as a first impression of dentistry, right? Now add in a mom who's about to witness her child go through that, and as if that's not enough, let's also throw in a first-year pediatric dental resident who, in a moment of sheer naivete, asked Dr. Carey for a challenge. Well, let's just say be careful what you wish for, because this was the perfect storm of circumstances for a truly unforgettable learning experience. And this perfectly sums up that day in the clinic. Like any good story, of course, there's a twist at the end. The day after Matthias's appointment, his mom called the clinic and says his school is reporting that he was throwing up and spiking a fever. Dr. Carey, the ever proactive one, asked her to bring him in. So we take a look at his vitals from the previous day and notice that his temperature was documented as 111 degree Fahrenheit. Yep, you heard that right. At first, I was concerned about systemic involvement, which means we should have prescribed antibiotics, but vomiting isn't typical for dental-related systemic issues, so that helped steer us away from that concern. And just as I was getting ready for another round of panic, Matthias's mom calls back and she says that he was feeling better and he would need to come in. And of course, we went back, reviewed Matthias's vitals, and somehow the pulse became the temperature. I mean, if you're going to mix up the numbers, why not throw in 111 degree Fahrenheit pulse, right? Apparently, my brain and adrenals were running on overdrive and my fingers weren't keeping up with the paperwork. So the lesson I learned there is triple check those numbers before I give my patients a heat wave. Before I wrap things up, I just wanted to take a moment to thank Dr. Carey, not only for giving me an opportunity to present today, but also challenging me and helping me grow as a clinician. It's not every day you get to make mistakes and still be supported. So thank you, Dr. Carey.
Thank you so much, Dr. Chachappan. That was wonderful and funny at the end. And does anybody have any questions or regarding around the case, or any general questions, comments? I see one question in the chat from Dr. Shah. Any standard format of prescribing antibiotics, standard number of days, standard potency, constant number of days, also same thing for alternative medications, and also any faster way of calculating dosage based on weight.
And thank you, Dr. Shah, for that question. And so just to reiterate, this presentation and stewardship recommendations are in the context of being able to provide treatment to the patient. And so there might be people in rural areas or other places that might have challenges to providing treatment. And if actually getting in and providing treatment is a barrier, certainly one can consider providing antibiotic therapy coverage until definitive treatment can be established. But if there's no barrier to having access to definitive treatment, there isn't necessarily a standard. Generally shorter, I do go for the shorter course of 3 to 5 days of antibiotics. And my goal is, if a patient does have facial cellulitis, I would like to have that patient come back by the 3rd day that they're on antibiotics. I get a little nervous when they're left longer. Certainly, antibiotics can buy time, in that if you have a flare-up, the infection can subside with the antibiotics. Sometimes patients feel so well they don't come back until they have another flare-up. And so I've found that you can get at least a month of coverage with providing an antibiotic to a patient who warrants it. It'll support the prevent the spread of the infection, make them feel a little bit more comfortable. But to remove to definitively remove the source of infection, and to prevent any significant complications, I would want to see my patient back between 3 to 5 days, preferably 3. If it's a long weekend, sometimes that can cause you to go beyond 3 days. So generally that is what I would recommend. As far as calculating, it's still going to be based on weight. There are apps that can calculate faster. So once you put the patient's weight in, it'll give you the dosing. And there are some charts that generalize dosing for kids, but it still will require your input with the weight. And that's one area where we slightly differ from pediatric medicine, where they have more standard dosing for example, for otitis media. They have a standard dose if it's severe or if it's moderate or mild. So we have range of doses, and it could vary across provider for the same patient with the same weight, and all are supposedly still correct. So someone can prescribe half as much, or someone can prescribe twice as much. And based on our guideline, that's still correct. And so I would like in the future to see the AAPD guideline or our recommendations for managing odontogenic infection get a little bit more specific with dosing. What is the correct dose? Because it can't be twice or half. But that's where we are, unfortunately.
Thank you. And I see a lot of thank yous for Dr. Carey and Dr. Chachapan in the chat. And another question from Dr. Flynn. How would you deal with a post-op infection with a pus?
Thank you, Dr. Flynn. A post-op infection. I get this question generally from persons who are dealing with permanent teeth extractions. I have, with primary teeth, very seldom, or I don't think I've ever had a post-op infection with pus. And so if your patient has systemic infection, like our patient had mild systemic infection, and so mild buccal swelling, and one could have certainly prescribed antibiotics to provide just coverage from flaring up since he already had a systemic involvement. But if your patient does have post-op infection with purulent discharge, you definitely want to provide antibiotic coverage for that. But generally, it doesn't happen with primary teeth if you've removed that source of infection. And I had one patient who had a systemic condition, but there's not significant literature on the correlation of that condition and dental findings. And I did have a patient end up with a post-operative facial swelling, and a very interesting clinical presentation that I had not seen, nor any of my colleagues who I had reached out to. So in that rare instance, it is advisable to go ahead with an antibiotic coverage for at least 3 days.
Thank you, Dr. Carey. I think we have time for another question or two. Anybody? Any questions, comments to share, experiences to share with the group? Right. Karen, please share the conclusion slide. And thank you again, Dr. Chachapan and Dr. Carey, for a wonderful presentation. And thank you to everyone for joining us for the 24th Dent Echo. Please complete the post-session survey. The link you can, I believe Karen has already dropped in the chat. And we hope to see you in 2 months in March for our next Dent Echo. Thank you again and have a great rest of the day.